Hello, everyone. Thank you, James, for the invitation. It's great. It's my first time here in these meetings. So we'll try to summarize which are the complications that general surgeons should manage for the bariatric patient. So this, James mentioned something about this, but look at, 61% of the patients got a sleeve gastrectomy, and that trend is going up, and bypass is going down, even though we know it's one of the best operations. And revision, as you can see, is 15%, and mostly of those revisions are from sleeve gastrectomy. So these are the common procedures: sleeve gastrectomy, bypass, and banding. Banding, thank God, is not done frequently as before, but it was not very unusual to get these patients after band adjustment in the ER over the weekend throwing up with a large pouch enlargement or a band slippage. We don't see that much anymore. So these are the common complications. For the early and late complications: sleeve gastrectomy, leak, and fistula, which I think is one of the worst complications that any bariatric surgeon faces. Strictures, bleeding, of course the late complication is reflux. Bypass, again, leak and fistula, not as common as the sleeve gastrectomy. I think leaks on the sleeve are much more frequent. Obstruction, strictures, and of course bleeding. Ulcers is another big problem with the gastric bypass. We see that quite often. Patients with chronic pain that take a lot of NSAIDs or smokers. Perforation, we see quite a lot of these patients coming with perforation. Most of them, they have a posterior perforation, so they are not peritonitic, but they have either a gastrogastric fistula or a lot of back pain. And of course, the most important one is the internal hernia and bowel obstruction. These are the patients that we need to act very fast because it's very critical. Patients can lose most of the bowel from an internal hernia. And we talked about the lap band already. So this is a paper that they see in a BC bariatric clinic, hospital, the most common consultations in the ER for complications. As you can see, internal hernia is 50% of what they see. Small bowel from adhesions, stenosis, intussusception. Now, intussusception is very common in the patients with a gastric bypass, and most of them, you should not rush to operate them. Sometimes the CAT scan will come back with saying patient has an intussusception, and what we do the following day is do a small bowel follow-through, and most of them resolve without any surgery. So don't jump into operating intussusception because most of the time resolves by itself. Leaks, perforations, ulcers, and so on. So the earliest, as we already said, was